Hi everyone, it's Wednesday. Welcome to Wisdom Wednesday. Hope you all are doing well out there. Last week we did kind of a short review on insulin resistance, and I want to carry that through a little bit into this week's discussion. I want to talk a little bit about estrogen and estradiol. I had a lot of folks come in, and of course we do a lot of hormonal therapy. But a lot of women continue to be concerned, obviously, about the risk of breast cancer and taking our hormones. And I just wanted to kind of walk through this with you. I've just gotten back from my hormone update meeting, and I continue to be very favorably encouraged with the science, not what is common consensus, but with the science that continues to, I think, support the use of hormones even in women who've had breast cancer. And I want to walk through that so that you can understand that, because I think we all have this idea that estrogen can feed breast cancer. And I just want to kind of give you a simple explanation of why this seems to be common thinking and why I believe we should be able to move on from that. You know, studies have shown that at baseline levels that, particularly in postmenopausal women, even women who are not on hormones have an increased risk for breast cancer when they have high levels of estrogen and testosterone as well. So let's just talk a little bit about estrogen first, about what it does and what happens when we lose it. So, you know, we all lose it at menopause. Our levels go down and we begin to just feel horrible. We're achy. We have sort of feel like our skin is drying up. Our joints are more uncomfortable. We know vaginally things begin to change down there. It begins to get drier and more uncomfortable. And what we see too, just in the science part of it, as far as our overall health and wellness, we begin to see a decline in overall health. We see an increase in cardiovascular disease. We see an increase in cerebrovascular disease. So that's heart attacks and strokes, increased risk of type 2 diabetes. Definitely we see an increase in neurodegenerative changes as we age, dementia and Alzheimer's. We know from a bone health standpoint that estrogen is vital for optimal bone health. So we begin to see thinning of our bones and osteoporosis and fractures. And we also see that there's changes in our eyes, increased risk for dry eyes and macular degeneration. And based on the Women's Health Initiative, also an increased risk of colon cancer. So this is what happens when we lose estrogen. Now, when we add estrogen back, we see that we overall see improvement in mood, and I think a lot of that has to do with the depth and quality of our sleep. So I do think that estrogen has marked benefit on our sleep. That's one of the early things I see in most of my patients as we entered sort of perimenopause, is we start to see sleep disruption, and I think estrogen definitely has a role in optimizing our sleep. We know that there's just increased illness and death related to all causes with the loss of estrogen. We lose memory and cognition and balance. Of course, the bone health. We see changes in lipids too when we don't have estrogen around. The HDL tends to fall, LDL tends to go up. And we're going to be talking a little bit more about that as we move forward on some of these Wednesdays too, about what's really important where our lipid panel is concerned. Definitely changes in temperature and loss of sexual function. As far as just desire and response is concerned, and we definitely see skin changes. As what my mentor tells his patients, they always ask, you know, when should I come off of all these hormones? And he says, as soon as you're ready to start aging. And so I think that's kind of an interesting response in terms of what really happens when we lose our hormones. We begin to age, and much more rapidly. So getting back on a program can be very helpful. But what about the risk? Is there a risk? And I think that's the thing I'd like to kind of touch base with you today, is that I have patients all the time say, you know, I got a friend that has a breast cancer and it's that estrogen feeds it. Well, I'd like to just share with you some just real information here regarding that, because that's just such a misnomer. What we know is that estrogen is a hormone in the body, and practically all cells have estrogen receptors. In particular, breast cells have estrogen receptors. So estrogen receptors on a breast cancer cell means that it's more like a normal cell than an abnormal cell. But that's one of the things that is measured when we're looking at the differentiation of a tumor cell. We hear the term well-differentiated tumor or poorly differentiated tumor. A well-differentiated tumor looks more like its normal cell of origin. So if a breast cancer exhibits estrogen and progesterone receptors, that is a very good thing if that is a tumor that you have, because it's much more like a normal cell and therefore is not as what I would call a bad actor in terms of its potential for metastasis and full body damage, let's just say. So that's not necessarily a bad thing, but to go from there and just say it's an estrogen-fed tumor, so we've got to get rid of all the estrogen in the body is, I think, premature. Because what we begin to see in the studies is that when we give estrogen to people who have had a tumor, even with an estrogen receptor, the recurrence risk is less. When we look across the board, first of all, let's think about breast cancer in terms of what we see overall. Now, it's not always the case, but in general, breast cancer occurs in postmenopausal women when estrogen levels are low. They may not be zero, but we see them more frequently in women with disorders that have some issues with estrogen, particularly people who've had a history of PCOS or polycystic ovarian syndrome, and people who are overweight. And what we know about these people is they have higher levels of hormones inside their cells because they are insulin resistant for the most part. And I think that's something that we need to keep in mind. As I said, we talked a little bit about insulin resistance last week, and what we see more frequently in women with a history of breast cancer is the fact that they may have higher intracellular hormonal levels because underlying the whole thing is that there is this sort of baseline issue of insulin resistance. And perhaps that's where we need to go in the future with looking at treatment, because taking away estrogen from everyone in terms of treatment, even after breast cancer, is minimally helpful at best. But when we do look at the studies and we look at women who've had a history of breast cancer who are given hormonal therapy, the recurrence rate there is 9%. In women who do not go back on hormone therapy in any way, the recurrence risk is 20%. I think that speaks for itself, and that's review of many, many studies that have been done in the past. Now, of course, in our world, we are much more geared toward bioidentical hormones and bioidentical estrogen. But even in the studies with Premarin, and we can go back even to the Women's Health Initiative, there was no increased risk of breast cancer in the Premarin-only arm of that study. So I think we need to really look at the science and see if we can, even though we've targeted this issue, perhaps there's an underlying target beyond estrogen that we can begin to look at. And it is my thinking that honestly within 10 to 15, 20 years, this will be off the table and we'll be looking at other ways of trying to minimize breast cancer risk, but also recurrence. And I do not think it's going to be with utilizing hormones. Just my personal belief. Anyway, I just wanted to help reassure you, but mostly I wanted to teach you a little bit about the fact that we don't need to fear the fact that if there is a breast cancer and there is an estrogen receptor, it doesn't mean that estrogen feeds it. It just means that it's more like a normal cell than an abnormal cell. We've targeted the estrogen receptor as a way of trying to treat it, but it's minimal at best and it's not foolproof, and I do believe that we need to look at other areas for treatment. I hope this has helped clear up some information for you. Please let us know if you have any questions, and I'll be happy to share any literature or any other thoughts with you. It is something that we need to, be mindful of. And unfortunately, this is just sort of common consensus today and not necessarily based on the science that we see when we look at the literature. So anyway, hope you all have a great day. Enjoy this beautiful weather that we're having right now, and we'll talk again next week.